call a sample in CMR4 shows this on the right side. The minimum sample quality, which would be required to call a BCR-able negative sample in CMR4, would be 10,000 able copies, because one BCR-able divided by 10,000 is 4 log reduction, is 0.01%. For the 4.5 log reduction, you need half a log more than 10,000. It's 32,000 able copies. And to qualify for CMR5, you need 100,000 able copies. And if you ask me if this is achievable, I can tell you CMR5 is not achievable in most labs on a general basis. So good labs achieve CMR 4.5 in the median of their samples. And since we had to find a solution for 13 European labs in common, we agreed on using the CMR definition as a primary endpoint for the NS first trial would be 10,000 able copies, because that was really an achievable aim. You see, the C is being X'd out, and the reason for that is that we found it would be much more logic to just qualify the level of the depth of the response by telling or naming it molecular response on a 4 log level, molecular response on a 4.5 log level, because it can be positive or negative below that specified level. And so the term CMR should be avoided. What I just told you is recently published in this paper in leukemia from Nick Cross as the first author. And here you find all these things in more detail. So what I want to tell you is that it's all about the sensitivity. Even though that the PCR methodology itself is a quite sensitive methodology, it's all about the sensitivity that you can achieve in the respective sample. And these are the main factors as we realize that. The number of leukocytes to use should be at least 10 to 20 million that you extract. The RNA extraction methods are so different. The old trisol methodology with chloroform and phenol is still the most valuable thing, even though it's not it's laborious and some kind of dirty compared to the very comfortable kits that are available. But this is crucial for having a good sensitivity, or for achieving a good sensitivity. Also, the cDNA synthesis protocol and the used enzymes may have a huge difference in what you get out of your samples. So I'd like to conclude for the first part that the establishment and validation of conversion factors is feasible but laborious in the setting of about 60 European labs. It shows the necessity for continuous revalidation of conversion factors until the availability of commercial reference material, with the aim that the international scale alignment can be done in each and every PCR run, compared to only once or twice per year with these laborious sample exchanges as we do it right now. There are laboratories with unstable conversion factors, and these should rigorously examine their internal processes to identify potential sources of variation. And the aim should be to increase sensitivity in order to fulfill the criteria for MR4, MR 4.5, and MR 5. And if you increase your sensitivity, you automatically gain a higher precision of the results. And this is the main aim. So with this, I would like to thank all these participants in this European trial. And thank you, but we won't have questions right now, so I just continue with the second part of the talk about the long-term follow-up of the trials using nilotinib or other TKIs as first or second-line treatment in CML. And this shows how important a standardized PCR is. So important for prognosis of CML patients, independent of PCR, is the depth of the response and the time to achieve that response. And this is taken into account since many years, since recommendations exist, how to treat and how to monitor patients with CML. On the left-hand side, you see the definitions of failure and suboptimal response of the ELN recommendations. The last version is from 2009. And on the right-hand side, you see the NCCN guidelines, which are mostly used in the US. And you see there's not much difference between the definitions, but what is highlighted here are the 18-month time point. The ELN recommendations already have some molecular decision-making because those patients who don't achieve an MMR are at risk and are classified as suboptimal patients. But molecular endpoints do not play a major role so far in the ELN recommendations. I will review some data now from the last year, which brings up to a necessity that the ELN recommendations will be renewed, will be discussed and published in a new version. And I will show you the most critical points as I see that. The 12-month time point has been the most solid time point where a complete cytogenetic response has been determined as the most prognostic factor. And there has been one recent paper from the MD Anderson Cancer Center in Houston that confirmed that. This is a landmark analysis of patients having achieved a CCYR with a perfect overall survival on the upper curve, and those patients who didn't achieve a CCYR at 12 months had a significantly worse overall survival on the long run. Independent from that, the IRIS data, the 12-month IRIS data, as has been published in 2010 by Tim Hughes as the first author, also shows similar data that those patients who didn't make it below the 1% limit, which is supposed to be equivalent with the term complete cytogenetic response, that this molecular endpoint 1%, not achieving the 1%, is associated with significantly worse event-free survival. The German CML study 4 also confirmed that in last year, that overall survival is also significantly worse if you don't achieve a CCYR by 12 months. Nevertheless, the overall difference in overall survival is 5%, but it's still significant. If you use the molecular predictor instead in this CML study 4, what you can see here, you see a better distinction, obviously, with the 1% predictor. And as I said, generally the 1% is considered to be equivalent to a complete cytogenetic response. But nevertheless, with the molecular predictor, we are better in predicting a worse response after 12 months, after this time point. So 12 months seems to be even consolidated that a CCYR and the 1% is really critical. Let's look about the 6-month time point. What has been published there? Again, MD Anderson Cancer Center data of overall survival dependent on the achievement of a CCYR at 6 months, yes or no. Again, you see a huge difference in overall survival. This has been confirmed by the German CML study 4, again with a smaller difference in overall survival, but anyhow, it's a significant difference. But if we look for the molecular predictor again in this German CML study 4, we see that the upper curve does significantly better than the others. And these are the patients who have the corresponding correlate to a CCYR, so they achieved less than 1%. They are different compared to the other two groups. So at 6 months, it's a more strict criterion as we had it in the last ELN recommendations, but I will come later on that. So can we do even judge the course of a patient at an earlier time point? Yes, we can. The 3-month time point has been published by two independent groups. This is the group of the Hammersmith Hospital in London. They published this data of achieving roughly a 10% BCR-ABL expression after 3 months, yes or no, which results in a huge difference in overall survival, maybe a little bit too large, this difference, compared to what the German group found. Again, we found that BCR-ABL of less than 10% was associated with significantly better 5-year overall survival compared to those who didn't make it below the 10% limit. Just remember that the 5-year overall survival is 95% versus 87%. And on the next slide, you will find not the molecular predictor, but the cytogenetic predictor. And using the partial cytogenetic response leads to exactly the same 5-year overall survival. So it seems that you can interchange the partial cytogenetic response criterion with the 10% BCR-ABL, according to the international scale. So in our publication, our conclusion was that we should do an early switch in those patients